This is chapter 28 for reviewing asthma and COPD. So review the objectives in the front of chapter 28 in your textbook. And let's go over the difference between COPD and asthma. This is kind of a compare and contrast. Looking at them side by side, let's see what's similar, let's see what's different. So COPD can often be caused by smoking or exposure to secondhand smoke, occupational irritants in the lungs such as asbestos, industrial chemicals, dust, and air pollution, and also viral infections such as RSV or adenovirus. Now, COPD is a progressive disease of the airway that produces gradual loss of the pulmonary function. It includes emphysema, bronchitis, chronic bronchitis, and chronic obstructive bronchitis. Asthma is a chronic disease, but it's considered to be a reversible chronic disease. It affects the airways. It produces irritation, inflammation, and difficulty breathing. It's classified according to its frequency and severity of symptoms, and the risk factors for asthma include family history, exposure to tobacco smoke, including secondhand smoke, air pollution, allergens, and respiratory infections. So they have some similarities, respiratory infections, pollutants as such to irritate, also smoking. Now, the symptoms with COPD, the airflow obstruction causes shortness of breath, a persistent cough, wheezing, and increased sputum. And in asthma, a cough is usually present, as well as wheezing and shortness of breath. It's noisy or labored breathing. That's where the wheezing comes in. It causes a whistling or creaking sound and a decrease in outflow of air. It causes chest tightness and can actually cause you to wake up, so it has problems sleeping. In COPD, the lungs are chronically inflamed, and what we're going to do is work towards treating or managing the symptoms. And asthma, depending on the severity of the asthma, we will either treat an acute attack, or if someone has moderate to severe asthma, we may use maintenance medications to control the frequency of the asthma attacks. Now, here's a picture of what asthma looks like and the changes that are occurring. So asthma is kind of in a sense, a positive feedback kind of thing going on. It perpetuates. So it causes a bronchospasm, which in that spasm, it causes inflammation. And when the spasm occurs, it causes the mucous membrane to secrete mucus, and then that creates a mucus plug, and then it causes more swelling, and that causes more spasms. So it can be kind of a cyclical kind of thing. So you see here, you've got the edema or the swelling, the inflammation of the mucous membranes, and then it fills with mucus. It's being secreted and can cause a plug, and then of course you can't get air past there. Plus it's constricting in the same time. So in treatment, because we do have some similarities in the symptoms and what's going on with these different disorders, we often will have similarities in the treatment. So with COPD, the aim is to relieve the symptoms and relieve the airway obstruction, also to correct hypoxia. So people with COPD have a hard time with oxygen. Chronic bronchitis, they're hypoxic. And actually, when we talk about chronic bronchitis, we sometimes refer to the patients as blue blowers. They're cyanotic. They're hypoxic. So their skin and their nails and their lips have a bluish tinge to them. Sometimes we refer to emphysema patients as pink puffers. They get air that's trapped into their lungs. So they're trying to get that air out. So we want to correct that oxygen. They're not getting a good oxygen exchange on their own, so we may use oxygen therapy through a cannula to force the oxygen in. We also treat any other precipitating factors and or other comorbidities, other things that are going on. So the medications we use include bronchodilators, glucocorticoids, mast cell stabilizers, and those are similar to the drugs that we can use in treating asthma. However, in COPD, we may also use an antimucolytic drug such as acetylcysteine. Acetylcysteine will break down the mucus that may be plugging up the airway, especially in a chronic bronchitis. Now, in asthma, treatment includes avoiding the triggers. So if it's allergy-induced, allergens, avoid the allergens, or irritants or other triggers. It could be even stress, or it could be cold weather, could be exercise. It may require lifestyle modifications. Of course, if someone's smoking, they should quit. Home monitoring of their breathing, making sure their air in their lungs is coming and going properly, so we use a peak flow meter. And then medications, we would use rescue medications such as bronchodilators, and then maintenance therapies, which could include bronchodilators, glucocorticoids, mast cell stabilizers, as well as other medications. Generally, both of these will be treated with an inhaled medications, especially with COPD and the asthma. Occasionally, we will use oral medications. So talking about that delivery, so here's some photographs of different types of delivery modes. Meter dose inhalers. This one here on the right, she's using a spacer. To properly administer the medication can be a challenge with meter dose inhaler. By using a spacer, it will actually trap the medication in the chamber, and then the patient can inhale it. They do have children's spacers as well. That may actually have a mask that goes over the nose and the mouth. Now on the left here we see this child is using a nebulizer, and that's attached to a machine that has a compressor that aerosolizes the medication, and then it can be breathed in. So a metered dose inhaler is got a specific number of actuations or doses. It contains a medication and compressed air and sometimes a propellant. And each time that you give a spray, it gives a meter dose, a specific amount. Now, as I was saying, the spacers, here's a picture of a spacer. It's used with a meter dose inhaler to get all the medication into the lungs. That way it doesn't just get into the back of the throat when it's being sprayed in. Spraying it in and inhaling at the same time can be a challenge for the patients. This is a picture of a Respimat, which is similar to a metered dose inhaler. It's kind of the 2.0 version, if you would, of a metered dose inhaler. The metered dose inhaler in the previous screen had a propellant. It's kind of like a can of hairspray or anything that would come out of a can that sprays. It's got something in there. With a Respimat, the actual propellant is air. It delivers a very fine mist, as you can see in this picture. And it's also got a specific number of doses. So you have to prime it with the air and release it properly. Other ways to administer medication is through a granulated medication, using a spinhaler or what we know as a dry powder inhaler, DPI. Also your discus, your rotohalers, your spinhalers, your handyhalers all fall into this powder component. So different things. The medication may be already loaded into the apparatus, such as with a discus here that we see. The medication's already in there, and you would turn the dial and the medication would be activated. For this one, you actually bring this whole piece up around to bring the next dose in. It's actually got a counter right there. For some, you actually have to manually load. So you would take a capsule and put it in, and you would click something which would puncture the capsule, and then you would just insert it and breathe in. So this powder will go deep into the lungs. Now here's what a full nebulizer may look like. There's lots of different versions. So this is the mask and the tubing, and it's connected to this compressor pump, and you would put the medication in there, and it would create a very fine mist that the patient would inhale. It gets way down into the lungs because it is a fine mist. Now, it's important when using a nebulizer that it's cleaned properly. Now, with a metered dose inhaler, especially with a corticosteroid, you want to make sure to rinse the mouthpiece on that and keep that clean. Now, let's start talking about how we would treat these disorders. So, in treating asthma or COPD, there's basically two groups of medications that we use to treat them. We have the bronchodilators, so they're going to open up the air passageway so that it's easier to move air in and out. And that includes beta agonists, and those beta agonists could be short-acting, intermediate-acting, or long-acting. We also use anticholinergics, so like we talked about the nervous system, the anticholinergics are kitty corner to the adrenergic agonist, the adrenergic component, and so they have similar activities. Then we have xanthines, which are also related to an adrenergic agonist, and they can open up airways. So some natural products that have xanthines include tea, coffee, chocolate, things that contain caffeine often will have xanthines. Now, the other side are anti-inflammatory agents. So, anti-inflammatory because there's inflammation, especially with asthma, but also with COPD. We're either going to impede the inflammation or stop it before it gets triggered. So corticosteroids, of course, are the most potent anti-inflammatory agents. And then we have mast cell stabilizers. So a mast cell is a cell that contains chemicals that when they're released from the cell, if degranulation occurs of the cell, it releases chemicals such as histamine or serotonin or prostaglandins or bradykinin that would then cause inflammation. So it stops, mast cell stabilizer is going to stop that cell from breaking down and releasing those inflammatory chemicals. Leukotriene inhibitors, leukotriene is also an inflammatory chemical, and it's one of the big ones when there's an asthma attack. A leukotriene inhibitor is going to block the receptor. So even though the leukotriene is available to the body, it can't make a connection to the receptor, therefore it can't cause inflammation. So going on with these bronchodilators, they're beta agonists. The short-acting, they bind to the beta receptors and relax the bronchial smooth muscle and reverse a bronchospasm. And they also stimulate the beta receptors to activate adenyl cyclase, and that has to do with the cell release, the broncho, and cause bronchodilation. So it's your short-actings, they're going to have generally a rapid onset, but they're going to have a short duration. Your intermediates, your book kind of classifies anything that's not long-acting as short-acting, which is kind of a misnomer. So in these notes, I've also categorized intermediate acting. So they may work a little faster, but they're not rescue inhalers. They're not going to last as long as a long-acting, but they're going to last a little bit longer than your ultra-short actings. So the side effects: nervousness, difficulty sleeping, dry mouth, headache, throat irritation. Because they're adrenergic stimulants, they can cause increase in heart rate, arrhythmias, hypertension, palpitations, tachycardia, tremors, hyperglycemia, hypokalemia, and an increased insulin secretion. So short-acting, your primary short-acting is albuterol. Albuterol goes by the brand name ProAir HFA and Ventolin HFA. So the HFA has to do with the propellant that's in them. They do not interfere with the ozone layer. So these are meter dose inhalers. Here's a ProAir and here's a Ventolin. And then it also comes for a nebulizer. So the vials, the little plastic things that we see over here, are used in a nebulizer. So it's an individualized dosing. They come wrapped in these foil packs, and then you break them off. The brand name for albuterol nebulizer is AccuNeb. Albuterol is the most commonly prescribed medication to relieve acute symptoms. We use these as a rescue inhaler. It may be used as a treatment with the AccuNeb, but generally speaking, most often your albuterol is going to be a rescue inhaler. And there's going to be questions like, is the patient using them more than a couple times a month? Some people think, oh, if I only use it twice a week, I'm doing good. Well, no, your asthma is probably not controlled if you're using a rescue inhaler several times a week. The next drug is lev-albuterol. So you see here, albuterol. Lev-albuterol is a stereoisomer of albuterol. It's called Xipenex, and originally it came only as a nebulizer solution, but it also, I have a misspelling there, comes as a meter dose inhaler. Generally, it releases a little bit slower. It absorbs a little differently. We don't get quite as much of some of the tremors and the palpitations as a side effect that we do with the regular albuterol. Now, just a little trick for your patients. If they're not sure how much medication's in their canister, and the canister, you see a picture here of the canister, it can come out of this mouthpiece. If they put it in a glass of water, if it floats to the top, it's empty. If it sinks, it's going to be a full canister. So sometimes you can't tell by shaking how full it is. Now that's another thing. Meter dose inhalers need to be shaken before they're used. Of course, a dry powder inhaler, we don't want to shake it because then the powder would fall out. But your meter dose inhaler would need to be shaken. Now, your maintenance therapies for asthma and COPD. Using a beta agonist that's intermediate acting or long acting. Also inhaled corticosteroids, leukotriene modifiers, and leukotriene inhibitors, mast cell stabilizers, and xanthines can be used. These are control medications. These are maintenance medications. Patients need to take these on a scheduled basis. They are not what we call a rescue. So your intermediate acting bronchodilator, adrenergic agonists, metoprolol, which it goes by the brand name of Alupent. So that comes as a meter dose inhaler. Metoprolol, metoprolol, see, sounded like look-alike. You're not paying attention. It's easy to say the wrong thing. Metoprolol also comes as a syrup, and it also comes in a nebulizer component. Terbutaline is another type of bronchodilator that is a beta agonist. Now, this one is an exception in the names. Most of your alpha or beta agonists are going to end in EROL. So a beta blocker is OLOL, but a beta agonist is EROL. The exception is terbutaline. Some brand names for terbutaline include Breathine and Breath Air, but mostly aren't available anymore. Terbutaline is dosed in a tablet, so of course that's not going to be a rescue. It can be given as an injection. Then we have purbuterol, which is Max Air, and Max Air is an autohaler. Now your long-acting beta agonists include formoterol, which is here on the right, and then arformoterol, Formoterol is Floridil, and Formoterol is Brovana. We have an inhaler for the formoterol, and the Formoterol is a nebulizer solution. Then your other long-acting is Salmeterol, Ceravent Discus. This is a very commonly prescribed medication. You'll see a lot of these prescriptions going out. And it is a long-acting. It's not going to kick in for 30 to 60 minutes, so it's really important a patient doesn't try to use that as a rescue inhaler. Also, it contains a powder. The Discus has a powder in it. It's not an aerosolized. So the long-acting, the FDA indications and precautions for safe use. They're contraindicated without the use of an inhaled corticosteroid. Single ingredient long-acting beta agonists should not be used alone. Limit the use to shortest duration required to achieve the control, and restrict long-term use to patients whose asthma cannot be adequately controlled with a controller medication. Combination inhaled corticosteroids and long-acting beta agonists recommended for pediatric and adolescent patients when the use of a long-acting beta agonist is required. And we'll talk more about the combination drugs at the end of this lecture. A note on any of the inhaled dry powder inhalers: it's important if the patient has to load, the medication comes in the form of a capsule. It is not to be ingested. It needs to be put into the apparatus and punctured so that the powder inside can be inhaled. So sound-alike, look-alike: albuterol, atenolol, metoprolol and metoprolol, Combivent, Combivir, terbutaphine, and terbinafine, which is a antifungal drug. So not only do we use our beta agonists as a bronchodilator, but anticholinergics are also bronchodilators, and they bind to the muscarinic receptors, blocking the effects of the acetylcholine, stopping the cholinergic response. That relaxes bronchial smooth muscles. And also, because of the antagonism, it causes bronchodilation. The labels that would go on your inhalers: you want to use Shake Well on your meter dose inhaler ipratropium. And then the tiotropium is a powdered inhaler, so do not swallow the capsules, only for an inhalation device. Oops. Yeah. So ipratropium is one of the anticholinergics, and its brand name is Atrovent, and again, HFA for the propellant. And tiotropium is Spiriva. It's a handyhaler, and if you've had lab, you've already experienced how to use a handyhaler. And Spiriva also comes as a Respimat. Now, your inhaled anticholinergics have the drug stem of tropium. The last group of bronchodilators are xanthine derivatives, and these are prostaglandin antagonists. Prostaglandin can cause inflammation. They inhibit a calcium ion influx into the smooth muscle, stimulate your endogenous catecholamines. They stimulate epinephrine and norepinephrine, inhibit the release of mediators from mast cells and also leukocytes, and they are an antagonist for adenosine receptors. We don't really know how, we just know what. So they reduce inflammation, reduces bronchospasms, and also produce bronchodilation. Now, like I said previously, we find xanthines in food products like coffee, chocolate, and tea. So if you think about when you're sick and you have a cold and you're all congested and stuffed up and you drink hot tea and your airways feel better, part of that is from the xanthines. The drugs in the xanthine class are aminophylline, most often going to be administered through injection. We use it to treat COPD, but in an oral formulation, but it can be used as an injection for a stress test. So when people have to get onto a treadmill to get their heart rate up, a lot of times they have a hard time getting to the place where their heart rate is up because they can't breathe. So by using aminophylline, it helps open up their airway. Now, aminophylline is dosed based on ideal body weight. Theophylline is the more commonly used drug, and it has several brand names, but the most common is Theo24 and elixophyllin. So elixophyllin is an elixir, we see here. And then Theo24 is a capsule. We primarily use theophylline for COPD. It can be used for asthma, but it's most often going to be used for COPD. One of the challenges with this drug is once a patient is controlled on this medication, they need to stick with the same manufacturer. There is some challenges with bioavailability between manufacturers and or brand names. So it's important that they stay with the same brand. Now, your xanthines can cause side effects such as insomnia, dizziness, headache, irritability, decreased appetite, stomach cramps, and urinary retention. The warning labels for the aminophylline, if they were using the tablets, don't crush or chew for the extended release, and if they're using theophylline, they need to take 30 to 60 minutes before they eat with a full glass of water. One of the challenges with the theophylline in the dosing can be for therapeutic duplication. If a patient goes to more than one physician and one writes for theophylline and another writes for a brand name, the patient may get both filled, and that could cause life-threatening arrhythmias. So paying attention, if there's another order for theophylline in their profile, verify if it's a different doctor that they don't take them at the same time. So you want to bring that to your pharmacist's attention. So those were the bronchodilators. Now, three groups again in the bronchodilators. We have beta agonists, we have anticholinergics, and we have xanthines. So then we have the anti-inflammatory medications to stop inflammation. Used primarily for asthma, but can be used for COPD. We have glucocorticoids, we have leukotriene modifiers and leukotriene inhibitors, and we also have mast cell stabilizers. So the first ones we're going to talk about are the glucocorticoids. They reduce infiltration of the mediators of the inflammatory process into the airway cells. So they reduce mucus, reduce swelling that makes it difficult to breathe. They stop that inflammatory process. Mucus is a result of the inflammatory process. They decrease the synthesis of the pro-inflammatory substances, the prostaglandins, that get released in that inflammatory response. So side effects or adverse reactions from the medications, and this is especially with the inhaled, coughing, hoarseness, throat irritation, dry mouth. Can also affect taste, leave an unpleasant taste, cause flushing. But one of the important things is making sure that you rinse your mouth after using an inhaler, and make sure you rinse the mouthpiece on the inhaler, because if you don't, you could get thrush. So glucocorticoids have sugar in them. Going into your mouth, dark, moist, warm place, great place for fungus to grow. Sugar is its nutrition. Again, with your meter dose inhaler, they should be shaken well before use if it's got a propellant. So, as we talked about before with steroids, Zone or Lone or Sonide are some of the drug stems associated with glucocorticoids. Mostly for the treatment in asthma and COPD, your primary route of administration is going to be through inhalation. Again, glucocorticoids may be administered in combination with long-acting beta agonists. So the first drug is beclomethasone, which is QVAR 40 or QVAR 80, and those are meter dose inhalers, and it even tells you how many doses are left. Budesonide is Pulmicort, so it's a pulmonary corticosteroid, and it's as a flexhaler, which is kind of like a turbohaler, dry powder inhaler, and also as a respuel, which would be used in a nebulizer. The next one is cyclesinide, which is Alvesco, and that is a meter dose inhaler. And then we have fluticasone, which is Flovent discus, or Flovent HFA. Now, one of the challenges that I so remember from being in the hospital, we'd get patients who got admitted through the emergency room, and the doctor would write Flovent, but wouldn't give us a strength. It comes in multiple strengths, so you really need to know, is it 44 micrograms, 110, or 220? So sometimes we'd ask the patient, well, what color is it? And that would help us identify which inhaler it was. Now, the Flovent discus only comes in one strength. That's a dry powdered inhaler, where your Flovent HFA is a meter dose inhaler. Then we have mometasone, which is Asthma Nex. So we talked about mometasone in chapter 29 for the nasal inhalation. That was Nasonex. This is Asthma-Nex, so for asthma, and that's a dry powder inhaler. The next anti-inflammatory classification is a leukotriene inhibitor. Now, these work by interfering and binding with the cysteine leukotrienes, which are receptors on the airway smooth muscle. These drugs will bind and act as an antagonist, and it reduces allergen-induced airway inflammation and produces airway relaxation and reduces the edema, the inflammation component. For dosing of these medications, there's two in this group. We have montelukast and zerfelukast. So our drug stem for the leukotriene inhibitors is Lukast. Montelukast is known as Singulair. It's taken for asthma every evening. Exercise-induced asthma, a patient would take it 2 hours before they exercise, and then it can also be used for allergic rhinitis, which is daily. So this is the only one that actually will also work for allergic rhinitis. Zerfelukast alkylate is only used for asthma, and it's taken twice a day on an empty stomach. Now, these drugs will interact with the cytochrome P450 enzymatic system, so there are a number of drug interactions. The adverse effects are primarily due to the interaction with other cytochrome P450 drugs. But montelukast and zerfelukast can cause a cough, hoarseness, sore throat, headache, indigestion, heartburn, or stomach upset, and a runny nose. Now, montelukast by itself also can cause problems sleeping, dizziness, drowsiness, muscle aches or cramps, and unusual dreams. So montelukast is singular, and it comes as tablets. We've got a 2.5, a 5, and a 10 milligram tablet here. And also it comes as granules. So once the granules are open, you have to use them within 15 minutes, or then you have to discard them. So you want to wait until you're right before you use them. And oftentimes what we do with the granules is we will sprinkle them on applesauce or pudding or some kind of inch of food. Even grits in the morning would be great. Accolate is, zerfelukast is the generic name. The brand name is Accolate, and that only comes as a 20 milligram tablet. And you see here the name's actually printed on these tablets. So again, your drug stem is Lukast for your leukotriene inhibitors. Now, another drug that's a leukotriene modifier, so it's kind of like the leukotriene inhibitors, but not 100%. Again, it's also going to have interactions with the cytochrome P450 enzymatic drugs system. Its adverse effects, abdominal pain, and similar to the side effects for the montelukast and the zerfelukast. This drug can, however, have abnormal liver functions and jaundice as side effects. So it comes, the brand name, its generic name is Xyluten, and the brand name is Zyflo or Zyflo CR. So CR is controlled release, and you see that it's got different layers here with a CR. So the tablets look very similar. CT1 is the regular, and CT2 is the controlled release. Your warning labels for montelukast: take with a large glass of water, with a chewable tablet. Discard unused portions of the granules within 15 minutes. Zerfluca should be taken on an empty stomach, usually 1 to 2 hours after eating. And Xyluten, take with food and swallow whole. Do not crush or chew with your dosing. So be careful of sound-alike lookalikes again. Now the last group of anti-inflammatory drugs are your mast cell stabilizers. So mast cells contain chemicals that will be released when they're exposed to antigens. So if an allergen attaches, it will cause the cell to break down, releasing chemicals like bradykinin and prostaglandin and serotonin and histamine and leukotrienes, and those can go on to stimulate an inflammatory response. So there's only one drug in this group, and this drug is called cromolyn sodium. So we've already talked about cromolyn again in chapter 29 with allergic rhinitis, and that was nasal crom. In this context, cromolyn sodium improves exercise tolerance in reaction to cold air and environmental pollutants. So for exercise-induced asthma, this would be a good drug. Cromolyn sodium is not used to treat acute symptoms, so this is not a rescue, and it can take several weeks before the drug actually gets to a therapeutic level within the body. So the adverse effects of mast cell stabilizers, because inhaled, they can leave a bad taste in the mouth, irritated dry throat, cough, or wheezing. Cromolyn sodium can be administered using an MDI or a nebulizer, and in an MDI, be shaken well. Also comes as a powdered inhaler. So systemic absorption of cromolyn sodium is pretty minimal. So most of those side effects, the bad taste, the cough, and the wheezing from the inhalation component. So mast cell degranulation results in the release of histamine mediators. We administer this prophylactically. So, if you're going to go exercise, or not that it's an issue here, but in another part of the country, if you have to go outside on a very cold day, and that cold air can cause bronchoconstrictions. So one of the brand names for cromolyn sodium inhaled is Intal. So cromolyn sodium comes as inhalation solutions for a nebulizer. It comes as a meter dose inhaler. So we have Intal, and then we have the powdered inhaler, Intal. Now there is another group of drug that is used to treat asthma, and it's a immunomodulator. It's monoclonal antibody. Omalizumab is Xolair. It's a recombinant human monoclonal antibody, anti-immunoglobulin E. It's indicated for the treatment of moderate to severe asthma. And it's an add-on therapy for patients whose asthma can't be controlled with steroids and a beta agonist. So this is kind of a next step. Not every patient is going to be given this drug. The treatment is administered subcutaneously every 2 or 4 weeks. Now, black box warning on this, patients should be instructed to watch for signs and symptoms of an allergic reaction to the medication. They need to be provided instructions for self-treatment in the case of that emergency. Adverse effects localized to the injection, mild redness, itching, swelling, or bruising at the injection site, can also cause headache, nausea. If they have anaphylaxis, difficulty breathing, hives, skin rash, and also a patient should be aware that it could cause unusual bleeding. Now, this is a powder that has to be reconstituted. It is a natural product, so it is stored in a refrigerator, and the reconstituted solution has to be thrown away after 24 hours. So a little review here. Common endings. We've got phylline, which is a xanthine, so theophylline. We've got leucist for the leukotriene inhibitors like monoleucist. MAB for your monoclonal antibodies. But I'm going to throw in here the EROL, albuterol, for your beta agonists. and tropium for your anticholinergic drugs. Now, just a couple more slides. Combination drugs. So, a short-acting beta agonist with an anticholinergic. So, how this works is the albuterol kicks in first, and the ipratropium is more of an intermediate. So, it takes a little bit of time before it'll kick in, but it'll kind of carry once the albuterol starts to wear off. So, this goes by different names. One of them is Combivent, and Combivent comes as a Respimat. It comes in nebulizer vials, and it also comes as a meter dose inhaler. And you see that the packaging is very consistent. Then we have the nebulizer, which is known as Duo Neb, because you've got a duo of medications. And then here's just a generic version so that you can see that. Then we have long-acting beta agonists with a corticosteroid. Fluticasone furoate with vilanterol. That is a newer drug. That's called Brio, so you may have seen a commercial on that. So you see here that Brio, this newer drug, it's a activated dry powdered inhaler. Then we have salmeterol, which I've misspelled. There's a surprise. Fluticasone with fluticasone. So you've got your long-acting beta agonist and your corticosteroid. That's known as Advair Discus or Advair HFA. So the HFA being your meter dose inhaler, and then your Advair Discus, which comes in multiple strengths. And you can see here it has two strengths, 550. So the fluticasone is consistent with the 50, but the amount of salmeterol will vary in that dosing. I'm trying to double check that I said that correctly. Or is it the fluticasone? It's the fluticasone that varies, with the Ceravent being consistent. Okay, so I did double check, and it is the fluticasone that is first. So we have 550. There's supposed to be a 200. I guess I got two of the same. There's there's the 250, 100, a 250, and a 500. There's 50 micrograms of salmeterol. And long-acting again with corticosteroid formoterol with flumetazone is Dulera, which comes as a meter dose inhaler. And then formoterol with budesonide, which is a symbol. And that comes in different strengths here. So the budesonide comes either 80 or 160, with the formoterol being 5. And that wraps up chapter 28.